Thank you, Dr. Mahapatra. Dr. Jagia, you probably remember there are two papers now looking at randomized trials of using MR in dilated cardiomyopathy or diagnosing cardiomyopathies, and it showed that it doesn't make a big difference. Eventually, you come to the diagnosis just a little later, and the outcomes don't change. Will that change your practice of using CMR routinely for all cardiomyopathies?
Majority of our cases of PCM usually come for etiological diagnosis, sir, rather than, I don't think our cardiologists, are reading too much into prognostication of these patients. So majority of them usually come for the etiological diagnosis. So,
right, but the trial had looked at etiology also, and they showed that whether you go to the CMR route or the non-CMR route, the same proportion get the correct diagnosis at 6 months, and then their 1 year prognosis is not different. So it's something that's thought-provoking, and this is not a single trial. There are 2 trials now. So that might affect practice in future because it's an expensive test. Right?
I have a comment to make. This is Naveen here.
Right.
I think this is a really great session. Shows the immense value of imaging in the assessment part for Dr. Satish Govind. Satish, you did not mention some of the limitations of global longitudinal strain assessment by echocardiography. Are there any limitations at all that you know?
The limitations, one is that it is not entirely load independent. So there's going to be some amount of load influence over there. That is one. And secondly, the quality of the 2D image is very important. So if the quality is, if more than 2 segments are not sort of nicely seen, and if there is an issue, then it is not truly global. That is the other one. And then, of course, you have the arrhythmias where you really can't do it. So these are the 3 broad areas where it's still a challenge. And I think it's something which we have to keep in mind when we are looking at GLS.
Yeah, I think those are the very important limitations to mention, especially patients with poor windows. Strain would not be really reliable. And I think when you look at strain and the window is poor, you really cannot use strain at all. That's I think the very good point you made about the strain. See, the other thing is, of course, is when you look at the ejection fraction by echo, even if you get a number, you can actually see how the ventricle is contracting, and you know whether the number is more or less in the correct ballpark or not. But with the strain images, you really don't have that option. You really depend on what the number is provided when by the machine. So that's one of the other limitations also of strain. Mm-hmm.
One of the things that's coming up again with strain is we think it's a better measure by prognosis and other circumstantial evidence. But in the next few months, there'll be some data coming out which might again make us rethink about this. The enthusiasm is probably running ahead of the evidence. So this happens with any technology. There's a lot of enthusiasm, and then a little bit reality sets in, and then we know how to use it. It's an interesting area, especially when people are now going to LA strain, RA strain, which are thin-walled ventricles. Their validation is not as good. So, Dr. Govind, any thoughts about that? Do you guys do atrial strains also?
Yes. Coming to the first point, I think there's always this hope and hype, and we don't know where exactly it sits in between. But, again, looking at, probably you will, with you as a reviewer of these various articles that are going to come in, I don't know whether AI will sort of improve on the way we sort of interpret strain. That is number one. So maybe there is some hope in that, and probably, whether it can live up to the hype. And the second part is, there's still talk of 3D, which I think it's still going to be a long way in terms of how 3D strain can be, better marker. Hopefully, as the software improves, maybe we can have a better point as far as 3D is concerned. So those are 2 points. And coming to the LA strain, yes, I sort of have this package which is there available on the machine, and I do a lot of LA strain. So there are still, it's still a work in progress. There's still a lot of times I'm still sort of looking at new ways of how it can be useful, how it can be a problem. The wide variation is still an issue, but the numbers are definitely sort of looking promising, and especially now with the LA strain in terms of the pressure, where the traditional indices of the LV filling pressure doesn't really work. I think some of the recent ones, which are giving some numbers in terms of an LA strain of around 18 reservoir strain, indicates that there is LV filling. I think these are the areas where LA strain would definitely be useful, and of course the onset of atrial fibrillation also. I think two key areas where I would be really sort of looking forward to it.
Yeah, I agree with you, Satish. I think that's really a very good point you made about LA strain. I think that's really coming up quite a bit, and we all feel that it probably would be introduced in the guidelines in the very near future. I think artificial intelligence is really a big thing that is coming up. Although, of course, we know there are limitations to artificial intelligence depending upon whether you go for deep learning or not, and also there are some epistemological concerns regarding artificial intelligence in general. But I think that's something that would be very, very useful in echocardiography, would actually reduce the amount of time that we spent in interpreting images.
Dr. Christopher and Dr. Jagia, you can jump in too. The big elephant in the room in the CT area, photon counting CT. Any thoughts about it? That's going to revolutionize the way CT is being done. And the first machine was just installed, 5 months ago? Any thoughts about that? Or
heard about it, sir, but really no actionable intelligence just yet, still digesting the information.
Yeah, so this is already coming to clinical use, right? And the big thing about it is kind of is going to give you resolution. It's going to collect so much more information. It doesn't have to convert X-rays into light and then count it. It's counting each of the light photon that's coming out. And the thing that I'm excited is that you can bin it, right? The energy that comes out of the image, you can put it into different energy levels. And hopefully you can say, okay, I want the calcium out of the coronaries. I want the stent out of the coronaries. And then you can just do it as a processing maneuver. And then the pictures that I've seen are mind blowing. I mean, you remember they used to use spectral CT to get different iodine levels. That's all gone now. You can just get everything from one view. That's great.
Sorry, this is Dr. Dayasagar. This is a question to Dr. Chandrasekhar. This is with respect to the usage of MRI in quantification of the fibrosis as a predictor of the sudden cardiac death. Do you generally use it routinely in your practice for risk stratification of these cardiomyopathies before you put an ICD?
No, we have not reached that stage yet. There is a fair amount of evidence that increasing fibrosis predicts increasing events. Different papers have different cutoffs, but we don't have very strong data on what is the right cutoff to use, especially when you are denying somebody a ICD. You have to be very sure that these cutoffs are good. I mean, the panel is very illustrious and they may have some thoughts, and I like to hear. The trouble with prognostic studies is the author kind of creates a cutoff and says, above this, there's high risk, below this, there's low risk, right? Like you saw some of the GLS data, they're talking about GLSs of 6 and 7 predicting outcomes. I mean, 6 and 7 is you can look at the patient and know he's going to have events. You don't need GLS of 6 to tell you that, right? So a lot of these studies, the cutoffs are pretty artificial. They plot a ROC curve, and in their thing, they say, where do I find the best discrimination? That is not enough for clinical decisions. But I would like to know what you guys do in your practice.
Sir, 15% is what we're taking for HCM. That's a fairly
for certain cardiomyopathies. For certain cardiomyopathies, sir, the cutoffs are quite defined, and we do clearly mention, we do quantify, like in patient with HCM, we are quantifying and we are putting the exact percentage.
Right. Again, the 15% comes from the Chan circulation paper, right? That is one cutoff. After that, Milind Desai has a thing where it's continuous. So even under 15, there is the increasing risk. The trouble is, when do you decide ICD or no ICD? That's a far bigger decision than saying after 15% the risk increases or doesn't increase. So that is the difficulty, Dr. Dayasagar Rao, for us to translate it into a clinical decision making. Even in the HCM guidelines, they have not said that after 15% of LG, you should give a device. They just put it as a part of a score.
Yeah, I think these are very interesting questions. And one of the keynote speakers for the next IACI meeting coming up in October is actually going to be on photon counting CT. So we'll probably learn a little bit more about that when Dr. Ron Jacob gives his keynote lecture on that. I had a quick question again for Priya and for Joanne, and this is based on the topic that many of the speakers prior to the imaging session raised. They basically spoke about the fact that, particularly in India, we have the newly diagnosed heart failure, we have the patients who are on appropriate treatment, and then we have the patients who are either decompensating or refractory or moving down the slope to a certain thing. And there was also this very nice term which was discussed as cardiac rehabilitation. So currently, Joanne and Priya, we tend to use cardiac MR as, like you mentioned, is the etiology phase, the first phase, or maybe trying to make some distinct. Do you see any role in either CT or MR along this progression, along the pathway? When would you jump in and say this person needs a cardiac CT or cardiac MR? If other than just the newly diagnosed pathway, along the pathway of heart failure.
Okay, so yes, first of all, this is an evolving arena, as we all know, and heart failure is not a single basket disease. It's a multitude of disease entities that we have clubbed together and put it as heart failure. Right now, we are still struggling at the entry point, trying to make a diagnosis with CT or MR. But slowly, as the techniques are getting adopted, especially in India, which is still an emerging market in more ways than one, the utilization of MR and CT is very, very low. It's extremely low, very restricted to the metros at this point of time. So I believe that we are still searching. We are still looking for avenues where to use, where not to use, which is the best way to do it. And we know that we are a resource-constrained market also. So the clinical judgment, as Dr. Chandrasekhar already mentioned, is the hallmark. But as you go along, you want to add on evidences to help your cause, either to put a device, not to do a device, do a CRT, not to do. You have a 15 to 20% non-responder. How do you get better? Our insurance companies don't give a CRT like they do in the Western world. So you want the right patient to fit for the right CRT. So I think in this evolution, we are still searching. And we are looking at various jigsaw puzzles to get into place, whether the scar is a problem. I told you about the unipolar versus a decapolar catheter in CRTs that we have been doing as a group. Whenever there's a scar abutting the lateral wall where the vein is also going, the best vein, for example, we're telling the interventionist to do, for example, a decapolar catheter. When there's a tortuosity in the vein, we're telling them to keep the additional balloons ready or to use an angled deflector, for example. So we are just refining and retooling ourselves to get better and better outcomes at the lowest possible resource utilization. And in the developing world, this is very, very important compared to what you would find it sort of regular speak in the Western world. So at least in my more than a decade here, we've been really looking and searching and sitting with our intervention and clinical counterparts to see wherein we can fit these, wherein we can help them, assist them, and fine-tune our journey forward. So whether it's at the entry point, whether it's somewhere at the mid, patient not responding, for example, to the CRT, you jump in, do the CT, check it out, or towards the end when you're looking at a transplant possible candidate and want to make sure that there's nothing reversible, like an ongoing sarcoid, for example. We have done that with MRI and PET and suddenly found granulomas. Patients been managed like a DCM so long on JDMT drugs, and suddenly in the MRI, there's some nodes popping up. There is a edema somewhere. There's some scarring atypical. Then you do the PET, and they're all starting up. So we have picked up sarcoid along this journey, and then we have treated them and got better results. So this is an evolving area, and at least in the developing world, I can say that we have still not found the exact place. Thank you.
I think you mentioned one very important point, and that's the cost. I think the cost has really to be taken into account in any country, especially in a country like India. And I think from that point of view, it's very hard to beat echocardiography, which you can use in your office and not have, not to go, not have a special unit or special room. It's practically part of the, I think now it has really become part of the clinical examination, to my mind.
Correct. So if you have time for one question from the nuclear experts here, do you think PET is going to replace regular SPECT?
Okay, listen, if suppose, I have already mentioned there, the spatial resolution is very good and the quantification is good and sensitivity and specificity is around 4 to 5% more as compared to SPECT. If suppose there is a facility for PET right now in India, those centers who have got cyclotron best, so they are doing a PET perfusion imaging as compared to SPECT imaging. But when somebody is in private sector, they do not have access to the cyclotron. So definitely we first go with a SPECT perfusion scan. So that depends. But if you ask me which is the best, yes, PET is the best modality.
Yeah. What about after the ischemia trial? Is there a role for any of these ischemia testing anymore?
See, ischemia trial, yeah, correct. But there are lots of controversy also, Dr. Chandra. We have been talking in a lot of platforms we have discussed. But there are a lot of controversy. After that, there are lots of controversy. I don't know still, but in India, everybody having a poor ejection fraction of 20-22%, they refer the patient for a viability study. This is a routine thing which we get, viability study, resting position and viability to make a decision. So this is a practice which is there still with the cardiologists practicing in India. I don't know about US. Please tell me. Please tell us.
So, yeah, there is a very strong debate about whether we should be doing a lot of ischemia testing anymore. The CT guys are kind of winning in this area. So, because even in the ischemia trial, the sub-analysis showed that mild, moderate, severe ischemia didn't predict prognosis, as well as mild coronary artery disease on CT, moderate coronary artery disease versus severe coronary artery disease. So the CT got a big lift after the trial, and the guidelines also kind of reflect that to some extent. In the younger patients, less than 60, 65, CT is kind of getting pushed a little more than myocardial perfusion.
Okay. Thank you very much.
It's given us a great belief in medical treatment. Optimal medical treatment has developed a great fillip after the ischemia trial. That's great for a developing country.
Absolutely.
Just one last question. The EF itself, coming back to what you mentioned, I still have an issue with this mildly reduced ejection fraction. We have the ejection fraction with the winter observer or the inter going more than 5%. So if somebody has a 45%, can still be wrongly put in that place, could be a reduced ejection fraction or could be a preserved ejection fraction. So is there something which we sort of need to really look into that area?
No, we all are kind of closing our eyes and making these classifications. You are absolutely right. The variability on a 2D echo has been up to 9%.
Yes.
Right. And so when we make these guesses, and the MRI literature proves that MRI is far more accurate on EF than even 3D echo. 3D echo comes close to MRI, but it's still not exactly reflective. So you're right. I mean, when we say ICD or no ICD, 35% cutoff or 30% in ischemic, it's a guesswork, right? So unfortunately, there have been no trials looking at the role of strain, GLS, to use one way or the other. But when people have done cardio-oncology studies where they had serial EF, serial GLS, serial CMR showed far better reliability than EF. And the EF was all over the place. So you're right. I mean, we know this is a problem, but we close our eyes and use it in the guidelines.
Dr.
Nanda, would you agree?
Dr. Chandrasekhar, and just only out of curiosity, I want to learn from you about the
CFR estimated by the new digital spec CTs? Is there any experience?
No, I don't have it personally, but CFR has a lot of value, whether it's intravascular or whether it's through nuclear techniques or CT-FFR related blood flow measurements. There is a lot of value with CFR, especially in the PET literature. There's a lot of value. The exact question you are asking, I don't have that much experience. We have a lot of experience on PET CFR. So that is what we use, and we try to get to PET as much as we can, even over and above spec, because it gives you quantitative flow and lot of other advantages.
Sure. Thank you so much. I think we are running short of time. Thank you, Dr. Chandra, Dr. Naveen Nanda, for conducting the session so beautifully. Dr. Sanjay Biswamitra, Dr. Sanjay Gambi,